Go ahead and get started. Many thanks for all of you for joining us today. My name's Terrence Henry, and I'm Executive Director of TAMEST, the Academy of Medicine, Engineering, and Science of Texas. We're glad to bring together the greater research community in Texas here today to learn more about COVID-19, specifically the mental and behavioral health impacts of the pandemic. But before we start the presentations and conversations, I'd like to just briefly tell you a little bit more about our organization. TAMEST was founded in 2004 by then Senator Kay Bailey Hutchison and two Nobel laureates, Michael Brown and Richard Smalling. We have more than 300 members in Texas, all of whom are members of the three national academies, so the National Academy of Medicine, National Academy of Engineering, and National Academy of Sciences, as well as the Royal Society and the state's Nobel laureates. Our mission is to really bring together the research community in Texas in medicine, engineering, science, and technology to help foster collaboration amongst our researchers across disciplines, across institutions, and to help advance research, innovation, and business in the state. And since we were founded, we've had more than 225 TAMEST members, so members of the National Academies, either be elected to the National Academies in Texas or recruited to the state. I want to take a quick moment and thank our member institutions, without which we wouldn't be here and wouldn't be doing this today. We know that they're doing very important work for all that they're doing right now. So with that introduction, I'm very excited to get this session started. As I said, we're going to focus on the mental health impacts of the pandemic. We're going to have brief presentations from each of our three speakers, and then the second half of the session we'll devote to Q&A. We've received a couple questions in advance, and when we get to the Q&A portion of the meeting, you can submit your question to the panel using the Q&A function that's in the Zoom. The controls right down there at the bottom of your screen. So with that, I would like to introduce our moderator of our session today, TAMEST member Ellen R. Gritz. She's a member of the National Academy of Medicine and Professor Emerita of the University of Texas MD Anderson Cancer Center. And Dr. Gritz also serves on our annual conference planning committee, which we're really grateful for. So Dr. Gritz, I'll turn it over to you and thank you for moderating today's session.
Thank you very much, Terrence, and I want to thank all of you for joining us today. As Terrence said, the overall goal of this session is to provide a scientific perspective on the mental and behavioral health impacts of COVID-19, including anxiety, depression, and substance abuse, and touching on coping behaviors and clinical treatment options. We all saw the headlines today that we have passed the 100,000 death mark in the United States, a shocking and sobering number. Obviously, this affects all of us. The presentations will include state, national, and international level data, and will address the general population as well as specific subpopulations. The impact on healthcare professionals and mental health care practitioners will also be discussed. The panel will answer questions at the end of the conversation. It is now my pleasure to introduce our first speaker, Dr. Lynn Bufka. She is Senior Director of Practice Research and Policy at the American Psychological Association. Dr. Bufka.
I made the fatal mistake of forgetting to unmute. So thank you, Dr. Gritz, for having me today, and to TAMEST for inviting me to be part of this presentation. I really appreciate having the opportunity to talk about what is surely going to be significant mental health impact because of COVID-19 at both the individual and population level within the country and truly around the world. We know that this is a completely unprecedented experience for the average person in our country right now. it is having a significant impact on people's experience of their emotional and mental well-being. The implications still are unpredictable and potentially quite vast. We're all dealing with some degree of uncertainty, which often leads to anxiety. They have the potential impact of what isolation can do to those of us. There are increased experience of bias and discrimination from some segments of our population, including Asian Americans and older adults in particular, as well as individuals with physical disabilities, in discussions about how COVID treatment will be allocated should resources be limited. And we certainly are hearing about traumatic reactions from frontline healthcare workers. And we expect that we will hear some of that from people who've recovered and have spent numerous days in ICU. So there are many segments of our population who are potentially going to be impacted, their mental health will be impacted by this. But it's important to bear in mind that human beings are resilient. We do adapt to difficult situations. And there are things that we can do to adapt within these times. We try to think about what the focus is for our entire population, all of society, maintain a perspective on that. And that has been demonstrated to be helpful in coping with situations like significant periods of quarantine or physical distancing. So it is a challenge that we need to meet. And how we do that will have important implications for our overall well-being. I like to encourage people to think of it not as a threat to overcome, but as a challenge that we all need to meet in a way that's effective for our overall population health as well as our individual health. At APA, the American Psychological Association, we do an annual survey called Stress in America. Normally, we do this survey, gather our data in August of any year, but we decided to do something different in 2020. We're doing a series of monthly surveys to try to gauge the stress level in the US. Our first survey just came out earlier this month, and we had a significant increase in the average self-reported stress of respondents. This is the first time we've had such a significant increase in the, I guess, 13 years now that we've been conducting this survey. It's significantly higher than the average stress that people reported in 2019. Interestingly, the census also recently did a survey showing that 1/3 of Americans are showing symptoms of depression or anxiety already, and that it's higher among younger adults, women, and the poor. In our survey, we haven't looked at that data yet, but we did find that parents are reporting higher overall stress than adults who do not have children in the home. We find across all political parties and regions of the country that people are saying the government response to the current pandemic is a significant source of stress. For our respondents, the economy as a stressor, the number of people endorsing that has increased by half. So it was about 46% August, it's about 70% now, telling us the economy is a stressor. Work continues to be a stressor. That's one of the top 3 stressors in all of our surveys. So if you're interested in more information about the data, you can go to the APA website and look for Stress in America. But that gives us a pretty good snapshot that right now, people across the country are reporting elevated levels of stress as it relates to this pandemic. We are concerned about certain segments of the population that have even higher risks for adverse psychological outcomes as a result of the pandemic. We know that frontline clinicians are reporting a lot of distress right now. There have been research reports from China telling us that in the nurses and physicians who are treating patients with COVID, up to half of the individuals were reporting significant symptoms of distress, depression, anxiety, and insomnia. And when we look at research from previous pandemics, we get very similar results, that we are finding systematically that elevated levels of distress occur among the people on the front lines. And most of us who are reading the papers or listening to the news are hearing this reports firsthand. Some of you in the audience may be directly experiencing this or may have friends or family who are on the front line providing care to individuals with COVID. We know that they are completely overwhelmed in situations in which the hospitals are full of patients. Part of the challenge for frontline clinicians right now is that the organizational response within institutions has been a challenge. They have not had the supports that they need from the beginning in terms of the PPE, in terms of having adequate staffing, in terms of having their basic needs met. And when our basic needs are not met, that makes it that much harder for us to maintain the mental and emotional well-being that we need in order to do our jobs. And of course, this has significant impact right now for the ability of people, nurses, physicians, and others to care for people who are ill. And it also has a significant impact for these individuals down the road, as well as the potential for perhaps numbers of individuals deciding this is not the kind of work that they want to continue with and having a negative impact on the number of providers available to us down the road. Other essential workers are also in a very difficult situation. Because of the work that they do, they face an increased risk of infection for themselves, their families, and many are also bearing the public brunt of unhappiness about orders to wear masks, to be physically distanced, where the frontline workers are having to enforce these kinds of expectations. And the public has taken it out on these individuals. There have even been incidences of individuals being shot for trying to have guests, have customers wear masks as appropriate. The census survey is telling us that younger adults are having a hard time right now. We also have lots of data telling us that older adults particularly struggle with isolation. When people are isolated, it can lead to loneliness. That has negative health impacts for us. So we need to particularly watch out for younger adults and older adults right now and the impacts of social isolation on those populations. And of course, whenever we have a crisis, those individuals who are in groups that are lower resourced to begin with, who have already struggling financially, who have chronic illnesses, they're starting off with fewer personal and community resources, making it that much more challenging to manage the issues faced by a pandemic that's encompassing the nation. We have both the healthcare issues as well as the economic issues that are across our nation right now. And these individuals who have fewer resources have less to start with to manage all of this. So we've got those populations also at risk for more adverse psychological outcomes. We don't know yet what's going to happen to those who've been bereaved right now. Many of us, we don't want to lose a loved one, but if we do, we want to be able to be with that person as they're dying. And that's not the case with individuals with COVID. And then once a person has passed away, we don't have access to the usual rituals for grieving, for mourning right now. So the challenges around grief are going to be another area that we really want to watch out for the potential negative impact on overall well-being. And finally, those who have been hospitalized and have recovered from COVID-19 have faced their own experiences of trauma. We know how difficult it is to be in an ICU setting, to be on a ventilator. That's been documented in the literature for quite some time, that those experiences in and of themselves are challenging. And then you add in the fact that individuals don't have the resources and supports of their family, and that makes it even harder. So what do we need to do in order to really manage this situation well? We need to really, first of all of us, keep our foundation strong. Good nutrition, regular physical activity, adequate sleep, and maintaining social connection, even if we're not able to be physically connected to others, is very critical right now. This helps for our mental well-being, and it helps for our physical well-being. And there's some basic things that we can do to manage that. We really want to pay attention to how much news we are consuming, how we're using social media. That can be very challenging for individuals. For the people who are teleworking, trying to balance being at home and having sort of boundaries around what is work and what isn't are very important strategies to watch out for. There are strategies that we can use in the moment to help us calm, to focus, to relax, to ground ourselves, and to celebrate what's going well so that we aren't focused all the time on what is stressful and overwhelming. And we need to think about this in a tiered way. We need both organizational and public support for mental well-being, and that includes within the institutions within which we work and where we spend our time, whether it's in schools, universities, etc., as well as local communities. And then we need to think about the kinds of resources for mental and emotional well-being from support groups and hotlines, warm lines, as they're sometimes called, text lines, to very brief interventions that can be scalable and delivered across a wide number of populations, to then the individuals who are going to need more focused psychological and other kinds of health interventions that can be delivered via teletherapy. So these are sort of the big scope of what we're anticipating with this mental and behavioral health crisis, and opportunities where we can have a significant impact. And I look forward to continuing this discussion after our other presenters. Thank you.
Thank you so much, Dr. Bufka. That was an excellent overview and introduction to our topic. Our second speaker is Dr. Andy Keller. He is the president and CEO and holds the Linda Perryman Evans Presidential Chair at the Meadows Mental Health Policy Institute. Dr. Keller.
Well, thanks, Dr. Gritz. Pleasure to be here today. And I think Dr. Bufka gave us a great overview of kind of what's happening now and how we can be dealing with our mental and emotional wellness. What we've tried to do at the Meadows Institute, and that's kind of summarized on the next slide, is to model what's going to happen in the future, and lots of different things are going to happen. I mean, this is a different experience for all of us. Fortunately, in Texas here, while we're certainly bearing a lot of the brunt of this epidemic, it's nothing like the pandemic. It's nothing like what's happening to our friends and colleagues in New York State, where death rates are many, many times higher, where the health system was way more overwhelmed. And so we're having different experiences. We're also having different experiences, as Dr. Bufka said, across different individuals. And so what we tried to look at are what are the different disease pathways that we're going to see coming out of this. And there's going to be a lot of different ones. Healthcare workers on the front lines are going to have a different experience than parents at home, and then individuals vary by all the different factors that Dr. Bufka noted. So we tried to pick one factor that is very well correlated and that we knew was going to have kind of a universal impact given the mitigation efforts, and that was the effects of unemployment in the economy. We've already seen dramatic, unprecedented increases in unemployment, perhaps only equaled back during the Great Depression back in the 20s. And so we wanted to model that. Modeling is something I think we've all gotten much more familiar with in the past couple months. And so we're pretty much in March, we realized that we needed to start looking at this, and it was not without controversy. So one thing we didn't want to do was to have this become sort of a pawn in some sort of political discussion where people said we either need to, save lives from mental illness or save lives from the disease. We at the Institute believe that we can do both of those things. But we were careful in our timing and waited actually until late April to release our models because we wanted some of the decisions around reopening and the path to reopening to be laid out. And we just didn't think it was going to be all that helpful to inject in the pre-reopening discussion these statistics. The second thing, though, is actually the controversy in actually modeling deaths from suicide. There's actually a lot of concern about that. There's research that shows if we talk in the wrong ways about suicide and publicize it in the wrong ways, we can actually promote more suicide. Most of that is really focused on individual cases. We looked very carefully, talked with folks across the country, the NIMH, other experts about how best to release these findings, and we've felt if we took a population health perspective, we could mitigate some of those concerns. And I think the other thing we realized is we need to focus on these diseases. And yeah, they're hard to talk about and they have a stigma, but we just went over the 100,000 mark with COVID this week. We've lost over 100,000 Americans to overdose and suicide for the last several years. So we need to be able to talk about these diseases. So we focused on estimates, and I'll walk you through those in a moment. These have been used nationally by multiple folks. There's actually been subsequent reports by the American Academy of Family Physicians and others who've used similar modeling. So I think we're in the ballpark, but keep in mind that no statistical models are right, but hopefully some can be useful. And the use we hope that these have is really to help us prepare, because we weren't prepared for COVID, but we have the tools, fortunately, to be prepared for these other diseases we're going to talk about. So if we go to the next slide, you can see our projections that we're looking at from deaths from drug overdose. And it's not quite a linear projection. The projection, it's pretty linear, but it does vary a little bit so that you can't just divide by a given number. But we're looking at increases from a baseline of just over 67,000 lives lost in 2018, which is the year for which, most recent year for which total year figures are available. We could see with just a 5% increase in employment, that going up by by about 5,000 Americans, about 500 Texans, actually, we're about 1/10 of that. And right now we're more like about 10%. And what's going to be important is whether this is sustained. It's sustained unemployment and the toxic effects of the economic and other pressures that come from that. If we go to the next slide, we see this for suicides actually a little bit lower baseline and a little bit lower rate of increase. About 4,000 additional lives lost for a 5% increase, right around 8,000. About 60 Texans lost for every 1% increase in unemployment. And it's starting from a baseline. And if you put these two together, we're talking about over 120,000 Americans lost in 2018 to suicide and overdose. Potential of that going up to 140, 150,000, potentially even 160,000 if we have great depression era levels of unemployment. We'll begin to see that coming into clarity. But keep in mind, it's the duration of these effects and how long it takes us to come back, and also recognizing it's going to be different by different states, by different subsections of the economy. So it's going to be important to kind of watch that. And I think the thing we'd like people to keep in mind as you look at this is these are treatable and preventable disease states. Right now, best practice mental health interventions in primary care have efficacy rates of around 40% remission or higher, whereas what we typically see in clinical practice are 6% remission. So depression drives about 75% of deaths from suicide. And so we aren't employing the tools that we have right now. And if we go to the next slide, we kind of lay out that this is just one of many different effects that we're going to see. The effects go beyond the economy, trauma in healthcare settings, both folks on the front line from COVID, but also think about other healthcare workers who are having differential effects. Many mental health clinicians have been able to go to telehealth, but a lot of mental health interventions require you to go, like, for example, helping homeless individuals. You're going to have to go find that person and meet with that person. Doing that without protective personal equipment, because mental health workers were not prioritized. It was hard enough to get it to our frontline COVID workers. Was a tremendous stressor for those mental health clinicians. Quarantines affected us all, often if you're running a home school even more, or other stressors, if you have a loved one who's at particularly high risk. So these things all impact us, and they lead to diseases that are treatable, that we can, we're lacking the will, and we need to really deploy those more, just as we have to didn't prepare for COVID. We can hopefully prepare through more detection in primary care, more treatment in primary care that's evidence-based, and then being able to get people to the specialty care and treatment-resistant depression options, as well as addiction options that are available. We looked at other factors. Domestic violence correlates are actually a little bit less clear. I mean, there's anecdotal evidence that domestic violence is going up. Certainly, we know in some cases it does, but there's also social connectedness and other things that seem to mitigate or cloud that. So we're still researching that and trying to get some evidence on that. We are going to be releasing a paper in a couple of weeks on child abuse, and there are very clear economic correlates between child abuse and economic factors. Economically insecure children experience maltreatment at 3 to 9 times the rates of children in more economically secure settings. The Great Recession, if we look at that, it was associated with, interestingly, increased abuse, particularly where there was what we call a social father. This would be a male who is, the boyfriend or the new husband of the mother, but is not the biological father of the child. Particularly in those cases, we see increased risk of abuse, actually, although decreased neglect. And it's not entirely clear why that is, but you can imagine in the current scenario, in some ways, families are closer, so it's either going to create inflamed situations or potentially to be somewhat of a protective factor because you have more parental time around. So there's a lot of things that are happening. We're happy to dig into some of these details in the Q&A. I saw there was one Q&A on racial breakdown, and we'll talk about that, I'm sure, when we come back to do that. But thanks for your time. I look forward to what Dr. Kostin is going to share.
Thank you, Dr. Keller. Those were really fascinating data that you shared with us. It's my pleasure now to introduce our final speaker, Dr. Tom Kostin. He holds the Wagner Professor in Psychiatry, Pharmacology, Neuroscience, and Immunology at the Baylor College of Medicine. Dr. Kostin.
Thank you very much for the introduction. I'd also like to acknowledge Dr. Zhang, who's a part of the Chinese National Academy of Sciences. He was one of my students quite a while ago, but returned to China a few years ago, and has been a constant collaborator in these works over there. The next slide, please. I'm going to go over three kinds of studies. One is inpatient psychiatric care. Now, inpatient psychiatric care in Wuhan province, which was the center of this epidemic, they all have large inpatient facilities, the kind of state hospitals like we used to have. And this one has 586 inpatients. 258 of them were schizophrenia, and 33% of the COVID infected were schizophrenics. All the non-schizophrenic patients accounted for only 5% of this. So there was a 6.5-fold higher risk of infection if you were schizophrenic in this setting. And they're all basically the same setting. There's no individual rooms. There are multiple people in rooms. In terms of contrasting the infected to the uninfected schizophrenic inpatients, those who were infected were older, and that's been found in many other studies. They were more likely female. Now, this is different, and it's usually been males. And there was some confounding in these outside studies because many more outside contacts tend to happen with males than females. So when you have equal numbers of contacts, the females look more vulnerable to this. They were lighter, once again, opposite than the usual, but in general, females are lighter, and there are very few people in these settings that are actually overweight. More with medical illnesses, once again, fits with everything else, quite a difference, almost twice as much, and this has been in many other studies. The two things that were provocative out of this, one was that there were fewer smokers. One of the explanations that's been looked at, and this is a very big difference you can see, is that nicotine has anti-inflammatory properties versus, of course, all tobacco properties that are carcinogens. So this is not, back to this, I'm not recommending everybody get a nicotine patch to prevent COVID infection. The other was fewer clozapine were treated. That is, this was surprising. There was just a report yesterday that came out in JAMA Psychiatry of a single case of a clozapine patient treated in the United States who they said had a more severe infection. But in fact, this study that we have is based on many more patients than one, as you can see. And the explanation is not entirely clear. In general, clozapine does suppress the immune function of white blood cells, but in general, it also suppresses, in that sense, the inflammatory responses. And what's been clear with this illness is inflammatory responses very much drive the things that kill you eventually. Next slide. I'm now going to go a little bit more broadly. This was a survey that we did, a national survey. It was about 6,400 Chinese from the whole country. It was done in February. And the abstinent alcohol abusers, we were finding that 19% of them were relapsing in the previous month. The usual rate of relapse in previous studies that have been done out there is about 8%. Now, many of you will say, wait a minute, after you detox, the high rate of relapse. Well, it's a high rate, but these are people who have been abstinent for several months, and 8% is the high estimate. So this is quite an increase. Tobacco smokers who've been abstinent at this point for several months, 25% of them are relapsing back versus 10%, which is more community rate. So while the USA does not recognize internet abuse or dependence, it is considered a major problem in Asia, particularly in adolescents, and treatments include, even residential boot camps for 6 months duration. The internet dependence rate, the baseline rate in the country is about 3.2% nationally. Just to give you a comparison, schizophrenia rate is only 1%, so that they do consider this a big problem. The rate increased to 4%, which was a 25% increase from in the previous month from what it had been, and that internet use increased 20-fold among those who were internet abusers in the previous month, that is, these adolescents in particular. So it's clear that this is making for some interesting problems. The next slide, please. This was another study that we did in which we had, we've been doing adolescent surveys in the middle schools for several months, well, several times a year. And these are 14,000 adolescents. They were an adjustment that was surveyed in 5 cities in October of 2019. We then followed by a second survey in January 2020. So we're before the COVID infection and 2 months after the COVID breakout in Wuhan, China. These are cities who are in more northern China, south of Beijing, but certainly north and east of Wuhan. And 5 cities had low levels of community infection. They did have some, ranging from 0.35% to 1.3%, of course, much lower than Wuhan. The infection rates correlated with anxiety and depression, though, extremely high correlation. And in fact, that what we found was that the infection rates were accounting for over 50% of the variance in anxiety and depression. So in fact, even across these 5 cities with these low rates. So the rates of anxiety and depression symptoms ranged from 4% to 30%, so it's quite a range. And the COVID infections rates varied, again, 3.7-fold, while the symptoms varied 7.5-fold. So what you're seeing is that there's a disproportionate increase in the amount of symptoms that these adolescents are getting when they are fear. So it's their perceived exposure that does it. That's the big thing. So what accounts for the double symptom rate difference in these adolescents compared to the modest infection rate difference? That's in fact one of the questions that we're looking at the national academies over there in China. Next slide. So what about adolescent exposure risk to COVID between the initial assessment and the follow-up, the overall anxiety and depression? Interestingly, for those that were home and had no exposure or threat of exposure, their symptoms actually dropped with home confinement and the school closure. Depression actually dropped from 51% to 38% in these adolescents. Anxiety went down from 39% to 24% in these adolescents. The explanation, to be a little, I don't mean to be critical of the education system in China, but it is quite regimented, and kids feel under tremendous pressure, particularly at this age, because they're taking exams that will determine the rest of their future. So being home from school and not having to deal with the teachers and regimenting and things like that did lead to a significant drop in their anxiety and depression. However, 2% of the adolescents did have a family member with COVID infection. With this family exposure risk to their depression anxiety almost doubled. So the depression in those who were exposed when we did it after this COVID infection started was 61%. If we then compared it to those with no exposure risk, and this was done with a technique that allows one to adjust for multiple factors. We then also did some kind of anxiety assessment and exposed versus no exposure risk, and you can see 41% versus 24%. So this was using a cutoff on these depression and anxiety scales to determine what would be not necessarily diagnosable major depressive disorder or anxiety disorder, but it would be these two disorders. So what are the protective and risk factors for greater symptoms of anxiety and depression? Well, some of the protective factors was resilience. Resilience has been known for quite a while to be protective. The odds ratio was in fact 0.2 for anxiety, 0.5 for depression. Those are, of course, smaller than 1 odds ratios, indicating the protective effect. If you looked at emotional abuse risk, the odds ratios were 1.1 and 1.3. With this very large sample, it was, of course, statistically significant. But the 1.3 for depression may, in fact, have some real clinical significance. The other thing that was surprising was if you had no siblings. Having no siblings, being the only child, which is very common in China because they've had these policies in place for many years of 1 child per family, the risks of anxiety and depression were significantly lower if you had no siblings. That's something that we may need to keep our eye on in the United States. Next slide. So in conclusions in this about COVID in China, and again, you're not getting a lot of information from China in the last few months for a whole variety of reasons, but smoking, I'm not suggesting protects against COVID, but the nicotine does suppress a strong immune symptoms without suppressing antibody formation. Antibody formation is ultimately what protects you. There's more asymptomatic infection that's quite possible, and the ultimate COVID immunity is going to be a question that is among those that had smoking, for example. However, if infected and you develop symptoms, The smoking impedes your body's ability to effectively fight the infection consequences. It's because of all the other chronic diseases that in fact follow from tobacco smoking. So I don't think we should not make non-smokers nicotine dependent by using nicotine patches to prevent symptomatic COVID infection, but it is certainly opens the door for other types of nicotine related medications that have not been examined at all. And it needs to be. So COVID has increased smoking and alcohol relapse. It's also increased internet addiction, which we don't see as much here, but quite prevalent there. And family members with COVID really raises adolescents' anxiety and depression during the months of social distancing and confinement at home. And this will need to be very carefully looked at in cities such as New York, where these rates are quite high. And of course, Texas cities often would form a comparison. Thank you very much, and I'm happy to address any questions people have.
Thank you very much, Dr. Kostin. We're now going to open the virtual floor for questions, which you may submit via the Q&A on the bottom of your screen. I'm going to start out with a question that was submitted prior to the seminar by Claire Proctor from the Texas Tribune, and her question focuses on the mental toll that the pandemic is taking on frontline health workers, which Dr. Bufka addressed a bit initially. She's wondering about long-term possible effects on the profession, what kind of resources are available to those who are having trouble coping, and whether there has been a noted uptick in reaching out for support during the pandemic. Dr. Bufka, perhaps you would start off with addressing this question.
Thank you. It's an important question. We certainly want to have our frontline providers able to function at their best. What we're seeing is that there are challenges with getting support and providing resources to people on the front lines. First of all, nurses, physicians are incredibly busy. They're responding to alarm calls all the time. They're working long shifts and going home and exhausted. So finding the time for what might be traditional mental health interventions, it has been a challenge. It's also been a challenge thinking about who should be providing what kind of intervention. So we're finding more success in institutions where they're thinking about scalable opportunities along a continuum. So providing resources such as a calming break room that people can go to, where there might be relaxation videos playing or relaxing kinds of experiences in that break room, ensuring that the basic needs of individuals are met, providing opportunities for quick on-the-spot kinds of interventions, whether it's through printed materials, whether or not a psychologist or other behavioral health professional is connected to that particular unit of staff and already has an ongoing relationship and can do some work with them, to things like training staff on the floor, a segment of them, in skills such as what we call psychological first aid, so that people are there identifying those with particular needs, doing some peer-to-peer support, and then ultimately providing some brief scalable interventions for individuals who are really overwhelmed. Institutions such as the University of Rochester Medical Center have put together programs like that. The VA in Georgia, Emory, affiliated with Emory in Atlanta, have put together programs like that. And that seems to be doing a reasonable job of meeting some of the needs. We are not seeing a significant number of people sort of reaching out directly to mental health providers for support. And that may have to do with a lot of things related to stigma, related to consequences for licensure, things like that. But we want to try to shift that so people have the resources on site, make it easily available, and have the tools to maintain the best health that they can.
Are there other comments from the panelists?
Well, if I could just add that I think, the other thing we need to look at is how this evolves over time. Because, what we typically see in trauma reactions is people sort of overperform. And this is an unusual traumatic situation because it's lasted so long. I mean, it's just been ongoing. So the toxicity of the stress plays out differently. But we're probably going to see a cascade over time if it's like other traumatic events where we have, an initial phase of folks who present and have either increased rates of depression, increased rates of post-traumatic stress disorder. but then this can also weaken our resilience over time. So additional triggers further down the line. So for example, you know, you might be doing all right now, but maybe your marriage was stressed by this and you end up separating 6 months from now. Well, that could be a trigger then for PTSD then. So we really have to watch for this actually for years. And so this is something, again, where detection in primary care settings, broader surveillance, trying to be aware of, use the screening tools we have to find traumatic effects, depression effects, suicide risks. Parkland Hospital Health System is the only health system in America right now that has universal screening for suicide in every one of its clinical services. And when I was at a meeting last year at the Pew Charitable Trust where the American Academy of Emergency Physicians was there, other folks, I will not say who, but people were actually arguing against screening for suicide broadly because their excuse was that, well, we already have more people than we can help. And, you know, we really have to reject that thinking. I mean, you're right, we're not going to be able to help everybody, but we don't help everybody with diabetes either, but we try. We actually have a desire to help them. So that sort of steps that Parkland has taken, which I think can be modeled other places, we need to be doing that, not just for suicide, but also for trauma, anxiety, depression, because these are treatable diseases if we take a proactive stance.
Yeah, this is Tom Kostin. In addressing this question, I hope people can hear me. One of the things that, one of the professions that's not so worried about stigma are people in mental health itself already, psychiatrists, psychologists, nurses of various sorts. And we have been hearing from them. I certainly have been hearing from them. The most impressive thing I've been hearing from them is the frustrations with telemedicine. The telemedicine is not an obvious thing that's going to just work automatically. For the first couple of weeks, it was not working at all, particularly in the Veterans Administration system, where all of the mental health providers were told to shift to telemedicine. Well, the system was providing telemedicine services for about 200 providers. When you then end up with 50,000 of them all of a sudden needing telemedicine and are supposed to stay home rather than coming into the hospital, as you might expect, the system crashed, and it crashed a number of times, so that eventually many of the providers were coming into work where they were told don't come into work, and using their office to do their telemental health because the remote access simply did not work. And the federal government being what it is, you can't just remote access with Zoom or something else. You in fact have to use HIPAA protected systems. And it's eventually come to the point where, as many may know, we are doing healthcare over the telephone, paying, you know, Verizon telephone. This is not HIPAA compliant. There are real issues about how confidentiality may occur. This has been quite stressful to the providers. And so I think that it's not just it's coming up in the future. I mean, it's coming now. The other two ways it's coming right now is our trainees have been protected up till now, in that they have in fact not been allowed to see patients. That's changed. They're now seeing patients. They're seeing patients in mental health, generally without any of the N95 protective equipment or any of the other stuff. It's simply not available. Where this has become a particular issue is that this is also a problem when you do medical consults. Psychiatry does a lot of medical consults, and they go to the medical setting in which we don't know if the person has COVID or not yet, or whether they're transmitting it, but they're in the hospital for something that's medical. And the amount of protective equipment that is allowed, because there's been significant shortages. So I'd just say that in terms of just my personal experience with this in a, admittedly, you know, otherwise well-equipped academic setting and in a national system, which is the Veterans Administration, it's been painted as if it's all terrific and it's all under control. It's anything but under control. And I agree that PTSD is going to be an outcome that already, I think, the mental health professional is not stigmatized or afraid to admit to. So, yeah, thank you.
Dr. Keller, you want to add on to that?
Yeah, I mean, I think I have a little different perspective on the telehealth piece. I mean, I think part of what Dr. Kostin is describing is the transition, and I think the transition actually has been extremely chaotic in many systems. So I would say overall, I've never seen a change in healthcare happen as rapidly as we've seen the shift to telehealth over the last 3 weeks. I mean, you know, and if we go beyond sort of like personal anecdotal experience to research that's been done on telehealth in psychiatry, and that's really the only one I'm familiar with, the evidence is crystal clear that the efficacy of psychotherapy delivered over telehealth is equal or better than face-to-face. And it's interesting, some of the findings around increased efficacy on telehealth. If you think about what you're willing to write in an email to somebody versus what you're willing to say to them face-to-face, some of that sort of lower anxiety and more candor can actually be really helpful. There's actually emerging evidence and quite a bit of evidence for audio only also being very effective. You know, I think a lot of us actually I yearn for the days when I didn't have to be on Zoom and I could actually talk to people on the phone, because I don't like having to like always, you know, make sure I'm looking at the camera. So I think, so if you look at the research, and we actually have a really nice summary of that I'm happy to include in the materials that we send out, some national groups have put together. So it's not a panacea. I totally agree with Dr. Kosten. And there's also a lot of things you can't do. I mean, you certainly do need to have a lot, I mean, residential care, you can't do that, telehealth, you can't do outreach to folks who are homeless. But most psychotherapies are amenable to that, are quite effective. And I think we have to weigh against maybe some of the practitioner frustration, which I think is actually a big thing, because people are used to practicing a certain way and don't necessarily like changing. We have to look at the dramatic increase in access. I mean, I was talking to somebody about rural mental health, and never before in America have people in rural settings had the access to mental health they have today because of all the waivers, of all the abilities, and there are HIPAA compliant ways to do it audio only. We just need to make sure that the technology catches up. The technology implementation, the technology exists, but yeah, I'm sorry.
So just as a follow-up from one of the from one of the Q&As, are there enough mental health providers in Texas to take care of this increased need? Have we seen statistics on the increased need? And how do people access resources?
Well, so we've looked a lot at the workforce in Texas and nationally. We don't have the workforce anywhere we need for mental health, particularly in child psychiatry, child mental health. But also there's a deployment issue. Mental health is one of the few disease sets where we have this expectation that you go straight to a specialist. And a lot of times that's great. But, you know, a lot of mental health happens in primary care. And so we've been trying to better leverage pediatric settings. The Texas Child Mental Health Consortium, the CARE Consortium, was put together last year with all of our medical schools, is getting supports to pediatric clinicians, you know, because most mental illnesses begin during childhood. So I think by leveraging primary care better and by trying to really treat more mild to moderate cases there, get people earlier, and I think we can better use the workforce we have, but we certainly need to be making more investments in training for all of our professions, not just psychiatry, and certainly child psychiatry and child mental health is probably the most desperately in need.
I could just follow up with one quick point. Another issue is ensuring that we provide interventions that are really scalable. In addition to what Dr. Keller said about not assuming we always need to go to the specialist level of care, when we do work with a specialist, we don't always need to assume that it's going to be multiple lengthy sessions, that there may be very brief focused interventions that could be effectively and efficiently delivered by specialists, whether they're embedded in a primary care setting or in other kinds of settings that will address the primary issues that someone is facing. And so having more models that we have the workforce being able to do that will also increase our capacity in providing care.
Thank you. We have another question on a different topic, comes from the Q&A list. Individuals who might be at higher risk for anxiety and depression that they have been managing up to now, but which they feel are exacerbating to the point that they are really suffering from isolation. These individuals wonder, what about the strategy of using social distancing and interacting on a one-to-one basis with friends if you find yourself really going beyond a point that you think is safe for yourself in terms of your own mental and behavioral health? Who would like to address that?
This is just Tom Kostin. As a physician and a person who's got some background in immunology and infectious diseases and what we're up against, if you think your physical health is is threatened by increased contact, by, I don't like to put it quite this way, by acting like an idiot like those people did at the pool in Missouri. I mean, that's suicidal behavior. It may be you're laughing during it, but that's just plain stupid. And I obviously have political views on some of this, which I'll try to keep to myself. But so that part of the question, you have to realize you are facing a potentially life-threatening disease. And it's not going to matter if you're 70 years old like me, then you have a certain amount of more risk than if you're 25. But it's not zero, and it's far from zero. And if you're a smoker on top of that, while nicotine might give you a little protection, it won't give you the protection that you can overcome from all the carcinogens that are in cigarettes. And as to vaping, just for people's information, we've actually been running some rather large studies looking at vaping in populations of up to 350,000. And what we have found is it actually potentiates suicide. And there's a reason that nicotine is probably doing this. So the reason that and by the way, the patches don't do that. It's the rapid delivery of nicotine that comes with vaping that does it. And the amount of nicotine that's in the vaping devices is miles above what you get out of a cigarette. I mean, up to 45 milligrams of nicotine are in those vaping devices. So what we're putting inside of kids is beyond belief. And there's data out of Korea that was published about a year and a half ago, looking at these devices and suicide in adolescents. It is a very strong association. So, yeah, sorry, that's my 2 cents.
Thank you, Dr. Kostin. We have time for only one more question, and a suggestion was made that, do any of you have any words on lessons learned from the great 1918 to 19 flu pandemic?
I have one big lesson that I'd like to emphasize. Most of the people that died during that pandemic were people in their most productive years. They were in people from 35 years old to 50 years old. That's where most of the deaths were. Now, we're hoping we can avoid that. We're obviously seeing it in the nursing homes now mostly, which is our older people. But this is the same kind of disease as that influenza was back then. It will kill you, and it won't care if you're young.
Dr. Keller.
So I would just add that, I mean, it's sort of an inverse one, but we're in a different world today than we were back then. I mean, we actually don't know how many people died from suicide in response to the Great Depression. There's a lot of anecdotal evidence, and people have tried to piece it together. Our best guess is a lot did. There was a lot of suicide following the crash and then following the depression there. We don't really know what the effects, though, were back during the great pandemic in 1918-19. And I guess that I would just kind of add to sort of what Dr. Kosten was saying, that we do know that deaths from suicide and opioids are affecting people in the prime of their lives. That's really where we are losing people. So I would say, let's try to chew gum and walk. Let's try to do two things at the same time and use the exact same methods. I thought Dr. Bufka's advice about overall wellness and resiliency, all the different things you could look at, are great things to balance the toxic effects of social isolation and quarantine. But we also need to remember that these are medical conditions that are treatable, and we need to give people the hope that we can help them, because the vast majority of people who suffer from depression, who suffer from anxiety, who suffer from addiction, we can help. And so I think that's the thing that is different that I'd like to make sure people keep in mind.
And one final point about the pandemic from over 100 years ago, you look at the data on places that did a better job with physical distancing, they had lower rates of transmission. Well, as Dr. Keller said, we're in a different era. That also applies to how we connect with people. So we can still maintain physical distancing, but use other ways to connect, to have that kind of ability to meet some of our emotional needs, our needs for social connection that are so sustaining. So while we can see that the physical distancing really does pay off and is really critical, others have talked about how critical it is to have that social connection and to be with each other. So we're in an era now where we have tools to facilitate that in ways that we did not have 100 years ago. And we really need to be creative with that as well in order to further our own well-being.
Okay, that's terrific. There was one other question that addressed the racial and ethnic distribution of some of the drug overdoses and suicides. I wonder if we have a 30-second response to that. Dr. Keller?
Yeah, real quick. So like I am the demographic at highest risk of dying from suicide, white men in their 50s. However, we've seen some of the highest increases in rates among women. Lowest rates of suicide, deaths from suicide are among people of color, African American, Asian American, Pacific Islanders, but the highest risk of all is American Indian and Alaska Natives, which is just dramatically higher. So you got that's the highest group at risk, white, Caucasians, the second highest, and then everybody else kind of clusters at a lower level. In terms of overdose, it's more complex, and Dr. Kosten and others have info on that, but I would add that deaths from overdose vary by group in terms of what you die from. So cocaine related versus opioid related versus methamphetamine versus alcohol. And I know there's others that have other perspective on that, but I would just add that.
Okay, that's terrific. We are planning a session on health disparities in the future, so we can go into that in greater detail. I want to thank all of the speakers and the audience for being with us for this hour. It has been a fascinating hour, and I want to turn the speaking now over back to Terrence Henry, who's going to make the conclusion. Terrence.
Thank you very much, Dr. Gritz, and thank you to all of our speakers for participating today, and thank you to all of you for attending. We're really glad that you could join us. As Dr. Gritz mentioned, we are planning future sessions on COVID-19, as well as other scientific issues, particularly that are having an impact in Texas. A couple that I'll mention that we're in the planning stages of are some of the lessons learned and innovations from manufacturing and sterilizing personal protective equipment, PPE. We're going to do a session on development of treatments and vaccines for COVID-19. And then also, as was mentioned by Dr. Gritz, a very important session we're looking forward to doing is on the health disparities that we're seeing from the pandemic. We did have an audience member ask if this session is available or eligible for continuing education credits. And while we're not set up for that yet, we are looking into having that set up for future sessions. So hopefully, as we move forward, there will be some continuing education credits available. This was such a great session, and we are going to have it archived on our YouTube page and our website. We'll have the video up, and all of the attendees will receive an email tomorrow with the link to the video, as well as the slides. And we'd really enjoy hearing your feedback. You'll have a link to a survey when this session ends. It has some opportunities for you to let us know how the session was for you, as well as hear your thoughts on future sessions that we should hold and topics that are of interest to you. And if you'd like to stay up to date on what TAMEST is doing and future sessions like these, there'll be an opportunity for you to sign up for updates as well, or you can just go to our website, which is tamest.org, to do that. Once again, I'd like to thank all of you for joining us, and most importantly, to thank our moderator and speakers for joining us today. I really appreciate you being here. Hope everyone stays well and stays healthy, and hope to see you again. Thank you.